Everyone, welcome to ToniTime, where solutions are just a discussion away. I'm Toni Land, President and Chief Experience Officer for Landing Exceptional Experiences, and your host of ToniTime. So today we are going to talk about the use of the word patient satisfaction and patient experience. Now, I just got to be upfront and tell you, it just like makes my stomach clench. I am triggered when I hear people use the word satisfaction. And as we go through today, I think you're going to see a little bit around why that word is bothersome to me. Words do matter. They paint a picture in our mind around the actions that are taking place. So it is important what words we use. But I thought we would start today really level setting around the terminology patient experience and patient satisfaction. And so I'm going to be reading a definition from the HRQ where they talk about what patient experience means, since that's where it originated. And patient experience from the HRQ says it encompasses the range of interactions that patients will have with the health system, including from their health plans, from doctors, nurses, staff in hospitals, physicians' practices, and other healthcare facilities. As an integral component of healthcare quality, patient experience includes several aspects of healthcare delivery that patients value highly when they seek and receive care, such as getting timely appointments, access to information, and good communication with healthcare providers. The terms patient satisfaction and patient experience are often used interchangeably, but they are not the same thing. To assess patient experience, one must find out from patients whether something that should happen in a healthcare setting, such as clear communication with the provider, did it actually happen, and or how often it happened. Satisfaction, on the other hand, is about whether a patient's expectations about a health encounter were met. Two people who receive the exact same care, but who have different expectations for how that care is supposed to be delivered, can give different satisfaction ratings because of their different expectations. So when we think of things around patient experience, saying what should happen in the healthcare setting, did it happen and how often did it happen, then we're thinking about things like cleanliness, courtesy and respect, understanding what to do when they go home. These are things that should happen and things that your CAP surveys will ask, did they happen and how frequently they happened? Always, usually, sometimes, never. So let's dig into a Reddit post where some of the clinicians and caregivers and team members are talking about their frustrations around patient experience, and you will hear them use the language patient satisfaction. So the post starts, when nurses start getting reprimanded by management for prioritization of care just because a patient complains, in other words, leaving the room of one patient to attend to another patient who popped off the ventilator rather than finishing putting a blanket on a patient, then that's just wrong. It's at the point where bedside is an absolute dread, and it's affecting the protection of our licenses. At what point do hospitals just become a Chick-fil-A? I mean, why is management sticking up for the ridiculous, nitpicking, dangerous, license-threatening request of patients instead of supporting their staff? I mean, where does the darn line get drawn? Where is the support? So you can hear this nurse's frustration around prioritization of care, and from their perspective, feeling like a patient's complaint or patient experience, patient satisfaction trumps all. Somebody says, well, sadly, healthcare is basically a service that is bought and paid for in this country, regardless of having insurance. So yes, people are going to be enraged when they feel like they are messed over by insurance companies. When you treat healthcare as a business, it should be expected that the consumer will be pissed if their experience is less than 5-star. When you have for-profit healthcare, the customer is always right, unfortunately. So interesting take there. Somebody else says, I hate to break it to you, but hospitals have been moving towards resort-style customer service BS for the last 20 years. Patients have become more entitled and less appreciative, and management has shifted all of these patient satisfaction surveys, and they have patient experience coordinators. I mean, I swear, when I see those patient experience people walk onto our units with their tablets and stacks of business cards, I just want to scream. Somebody else says, it's bad management. Patient experience has a huge impact on outcomes, but managers misinterpreting this as the customer is always right are totally off the mark. Patient experience is about clear, respectful communication and prioritization of safety. Administrators and managers who misunderstand this, that's the problem, not the philosophy. Somebody else says, yes, patient experience has ruined healthcare. Also, can we discuss how the whole concept of patient satisfaction is unreliable in the first place? I mean, nobody who's sick and in pain is exactly in the right mindset to be giving out a review. Also, you can go completely above and beyond for a patient, but the minute their food tray is wrong, you're suddenly a bad nurse and nobody here knows what they're doing, or it turns into nobody came to my room at all last night. It's exhausting. And it's why so many nurses are leaving the bedside. I mean, it's not even about actual patient care. It's just about the money. A customer service survey should only be looking for things that are fixable, actually fixable. The idea is you make your current survey taker a little grumpier, but prevent the issue for the next customer. So parking issues, delayed blanket due to maybe a neighbor coding, these aren't easily fixable. So you're burning goodwill for nothing. Somebody else offered a recommendation, and they said, here's some of the language I use. Multitasking delay. That means the nurse was doing something else that was also important and had to finish that task before responding to another request. And this can be stacked several requests deep. An example, why did it take 3 minutes to answer the call light? The response, there was a multitasking delay with 3 call lights at once. Another example this person gives, acuity prioritization. That means that the nurse had to deal with another issue that was higher acuity safety than the task at hand, maybe even leaving the current task. So, example, why did you not spread the blanket on the bed for the patient? The response, due to acuity prioritization, I had to respond to a fall alarm. Not bad examples there, not bad recommendations. So, wanted to include those in there. And then there was another post from someone who had been working with some physicians in a physician practice. And they admit, long answer here, but a few years ago, I was asked to do patient satisfaction, my stomach is clenching, patient satisfaction training evals for some docs who had issues with low scores. One of my visits was with a doc who had about 5 years and was in a new practice. I observed him on a visit with a man who was in his 50s. And the patient had a chief complaint of chest pain. And the patient had already had a very extensive cardiac workup by the previous doctor, the one who the new guy was replacing. And so this person doing the training evaluation observed a few things. The doctor stood behind the card with his EMR terminal on it and barely looked at the patient. When the patient asked about chest pain, the doctor replied, we've already worked it up and it was negative. And the patient asked about it again and was told the tests were negative, so you're fine. And then the doctor noted that the patient had a high LDL and recommended a medication. And the patient balked, due to some concerns over safety of the medication. And the doctor said, well, you really need it. The patient then just wondered if they could take half of the medicine instead. And the doctor told him, no, you need the whole amount. So the patient left, and this person asked the doctor how he thought the session had gone. He thought it'd been fine. And so I said, how likely is he to be taking that full dose of medicine the next time he comes in? Thought for a second, and he said, not very, I guess. And I said, well, yeah, he even offered you a compromise, and you really didn't discuss it with him. And do you think he's still worried about his heart? And the doctor said, probably. But here's the thing. If I hadn't brought any of this up, the doctor would not have seen it as a problem. There was absolutely nothing wrong with the medicine that the doctor practiced. The patient almost certainly did not have cardiac pain, and he didn't need this full dose of medication. But the doctor was so focused on the technical parts that he forgot the human parts. And, we talked about the art and science of medicine in one of the other videos. The patient left the office still worried about his heart and with a prescription that he may not have had any intention of taking. So you don't have to actually do everything they ask. No one's saying that. But you do have to address and allay their concerns. And it brings me back to a book we just read in our book club, The Empathy Effect by Dr. Helen Reese. Great read if you haven't read it before. But one of the things that really stuck out to me is she talks in the book about, yes, chief complaint. We're trained to ask that. But what about chief concern? And how do we start asking that question so that then we address the complaint and the concern and start increasing that adherence to the plan of care? So I thought that was a great example there. And then I'm going to read one more. And this was from a physician responding to a family medicine physician who was concerned because they were having low patient experience scores. And the physician responds, first, I'm so sorry that you're going through this. I think we can safely say that all of us wouldn't feel great about this, and that this could be any one of us at any moment. I don't think there is anything stronger than the negativity bias for a doctor than getting a bad review, a lawsuit, etc. And by that, I mean, if we recognize and acknowledge that for all we do, some patients may not like us, some patients may really like us. We may sometimes have a bad day, and that is not the definition of us as a person or a doctor. Some patients may have filled it out incorrectly. Some colleagues may be inflating their scores in a variety of ways. And there may be truly things that we can do better on and opportunities to improve our bedside manner that could raise our scores as we all start our careers, inexperienced by definition, and we improve over time. We intend to only hear the first one very loudly, and it overshadows all the other ones that are always going to be present. And so I like to say, and that's what this physician is saying, I like to say that every one of these uncomfortable moments is a time for reflection, not rejection of oneself or the situation. And then in that way, everything that is unpleasant that happens, it serves us as a beneficial opportunity to grow. Of course, that is in addition to it being very valid to be pissed and upset and fearful of consequences. But I mean that the other good stuff also exists, and it benefits us to see that as well. So I thought such an insightful response from this physician to one of his peers around, patient experience and patient experience measures and how to kind of ingest and process some of that feedback. So I thought that was very helpful. And so let's look at some of the data. I mean, what's the data saying to us? And then we'll talk about, and then what do we do with that? So there is some research that shows us that communication interventions at discharge are associated with fewer hospital readmissions and improvement of treatment adherence, along with improvement of patient experience measures. And this research shows at discharge, and I would just put a caveat that from my education and my learning, discharge starts on admission. So at discharge, and from my perspective, doesn't mean right when they're going to walk out the door. But improving communication there can also decrease, have an impact on some of these measures, readmissions and a treatment adherence. And so when we start thinking about using the word experience and thinking about the way some of the folks on Reddit have talked about satisfaction and Chick-fil-A and the patient's always right, and then stepping back and saying, if patient experience is around the things that should already be happening in our organization in order to improve outcomes, how do we start intentionally connecting those dots? How do we start intentionally connecting some of the communication measures to some of these outcomes like readmissions and improvement of treatment adherence? I will tell you, some of the literature out there says, some says 80%, some says 70%. So we're going to say 70 to 80% of medical errors are the result of miscommunication. Communication from team to patient and family, communication within the team, clinician and other team member miscommunications. So all these different miscommunications have caused have and continue to cause medical errors. Research also shows us that, yes, better patient care experiences, again, are linked to improved outcomes. You start seeing even an improvement in some of the prevention measures. You start seeing an improvement that clinical outcomes, better safety, and less healthcare utilization. So decrease in these emergency department visits and a decrease in those readmissions. It was some literature out there that actually showed that there's this link between patient treatment adherence and physician-patient communication, and that there was a 19% higher risk of non-adherence among patients whose physicians communicated poorly. So when we look at that opportunity of improving that adherence, which we know is going to impact other things, right? Emergency department visits, readmissions, we know it's in the quality of life for that patient. So we can talk about what does communication look like and how do we impact that. I'm going to give you one more piece of data here from the literature. Hospitals with the highest HCAHPS scores perform significantly better on CMS's clinical processes of care measures for AMI, congestive heart failure, pneumonia, and surgery versus hospitals with the lowest HCAHPS score. So we have an opportunity, and we can look at what specific measures, and I know we've talked a lot about communication here, but for the majority of organizations, the communication is a driver for your patient experience measures, your Leapfrog Hospital Safety Grades, your readmissions, your ED repeat visits. Communication is such a key driver around all of those. So let's dig into what do we do with all that. And today I decided to kind of take a stop, start, continue format. So I will say, what do we stop? Stop using the word satisfaction. It is putting the wrong picture in the minds of your teams that are directly and indirectly working with your patients and your families and connect it to quality outcomes. So when you hear it, use that as an opportunity to educate why we call it experience versus, satisfaction. And we're not always going to make patients happy, but we can always strive to deliver that safe, respectful, quality experience. Now, what do we start doing? We start reaching across the aisles, working with our quality leaders and our safety leaders, and we start looking at, are there joint goals that we could and should have? Are we intentionally looking at how certain measures are impacting the others, so that how our communication measures are impacting length of stay, or how they're impacting readmissions, how they're impacting how quickly a patient gets discharged. So looking at connecting experience measures to quality and safety outcomes. So that's what you start tracking and communicating to your teams, which engages them differently. Now, what are we going to continue? We're going to continue capturing patient feedback and team member feedback to determine, are we improving these goals? Are we improving these measures? Finding out from team members, where are the barriers? What's preventing us from moving forward? So when possible, they can help us think through how to remove those barriers so that we're truly seeing that decrease in readmissions and increase in medication adherence. We're seeing a decrease in some of these emergency department visits. We're seeing a decrease in calls to the desk. So these are important things for your team, and in order to be able to engage them differently and improve outcomes for patients and families. So I'm interested in knowing what's your organization use? Are they commonly using the word satisfaction? Are they using experience? Do you know what comes to mind for them when they say satisfaction, or when we say customer service or customer satisfaction? What are they saying there? Or patient satisfaction? What comes to mind for them? I'm looking forward to hearing your comments below around the use of patient experience or patient satisfaction and how we connect it to outcomes. Now, I want to tell you a little bit about landing exceptional experiences. So we are a group of patient experience certified professionals and Leapfrog certified coaches that partner with healthcare organizations to improve patient experience measures and Leapfrog Hospital Safety Grade. So as we finish our time together today, I want to tell you a little bit about landing exceptional experiences. So landing exceptional experiences is a group of Leapfrog certified coaches and certified patient experience professionals that partner with organizations to improve patient experience metrics and Leapfrog hospital safety grades. So I am looking forward to connecting with you and talking about some of the things that we talked about today on this video, and how do we put some of those things in motion for your organization in order to see increased engagement from your own team members and improved patient experience measures and improved quality and safety outcomes. The calendar link is below. Just click it for your free 30-minute consultation. Looking forward to talking to you soon. This has been ToniTime, where solutions are just a discussion away.